Hello, everyone. Welcome to this another interview with a Meet the Author. My name is Paul Mclaughlin. I'm the Vice Chair of the EAHAD Physiotherapy Committee, and it's my great pleasure to have with me today Dr. Merel Timmer. I'm thanking her for agreeing to take part to be interviewed about her most recent paper. So I'm going to ask Merel to briefly introduce herself, where she works, her research interests, and her clinical interests. So over to you, Merel.
Thank you, Paul, for the invitation for this interview. I work at the Van Creveld Clinic at the University Medical Center in Utrecht in the Netherlands. I have studied physiotherapy, human movement sciences, and clinical epidemiology. And currently I work as a physiotherapist, a postdoctoral researcher, and a lecturer in the master study of physiotherapy sciences. My interest, both clinical as in research, is directed at physiotherapy for patients with rare chronic diseases, in particular patients with hemophilia.
Lovely. So you're quite busy then with everything clinically and academically then. So we're here today just to have a chat really about Merel's latest paper, which was looking at the coordination of physiotherapy care for people with hemophilia in the Netherlands. And I, for one, was very interested in the paper, basically because it's never really been done before, what you did, and I actually looked at it in that way. And I think it's really, really interesting in regards to how perhaps the care of the future might look for large sort of registers for hemophilia. So just really to start us off, and for anybody who doesn't know you or doesn't know the Netherlands and the hemophilia setup there, can you briefly tell us about the setup of hemophilia services in the Netherlands? So sort of how many centers, MDTs, that kind of thing.
So the Netherlands counts 7 hemophilia treatment centers, of which 2 have 2 different locations in different neighboring cities. Most of the centers have different departments for children and for adults. Only in Utrecht we have 1 department for children and adults together, so all ages. So that's what we call the life course approach to healthcare. Although all centers have physiotherapists appointed for hemophilia, mostly both for adults and pediatric physiotherapists, the number of hours they have available for hemophilia differs widely. So some are more flexible and they can also see the patients when they come in with an acute complaint, but in other centers they are less flexible, and physiotherapy care is more directed at the chronic complications of hemophilia.
Okay, and the physiotherapy for hemophilia is free to people who have hemophilia, or do they have to pay to access services?
To access the services in the hemophilia center, they don't have to pay extra, but in primary care, they do have to pay for it, yeah. It's different for children, so I think until the age of 18, it's like in the normal healthcare package, but for adults, it's not.
Okay. So can you tell us what made you decide or want to carry out the piece of research that we're talking about today, looking at the care provision across the Netherlands? Why was it necessary? Why did it come to your attention, or the need to do it came to your attention?
Well, the Netherlands is a small country. Still, many patients have to travel for more than 1 hour to reach their HCC. And I think even in other countries that would be even more. So people in the Netherlands would not find that feasible for frequent physiotherapy visits. And therefore we work closely together with physiotherapists in primary care. But what we experience is that some patients are a bit reluctant to go to a physiotherapist in primary care because they are afraid that the physiotherapist has not enough experience with a rare disease as hemophilia. And also what we experience is that some physiotherapists feel the same. And that is why a good collaboration between HTC and primary care physiotherapists is very much appreciated by the patients and by the physiotherapists. And that is why we wanted to do this study and develop recommendations to further improve this physiotherapy care coordination for hemophilia.
Okay. And did so obviously you as clinicians identified that there was this sort of geographical issue and sort of some barriers to access. Was that also something that people with hemophilia had said as well, that they would want to do physio, but it was just too far away, or was it a sort of mostly the clinician's idea for this project, or half and half with the patients getting involved, or?
No, both. Like I think patients would definitely not travel for like an hour twice a week to go for a physiotherapy visit. So some live a bit closer, and then it's fine for them, but not for the ones who live farther away.
Mm. And so, give us a brief overview of the project that you did to look at the care provision.
Yeah, so what we did is that we asked patients and also parents of children with hemophilia, primary care physiotherapists that have seen at least one patient with hemophilia, and also physiotherapists working in the HTCs. We asked them with their experience. So with their experience with the treatment of patients with hemophilia in primary care, how did the physiotherapist experience that? How did the patients experience that? And how did all of those stakeholders experience the collaboration? And also how they would recommend to do it. So what kind of collaboration would they prefer? It gave us a lot of information, and that was a start for us to have a group discussion with some of the physiotherapists, so a small group of physiotherapists from primary care, patients, and HCC physiotherapists. And together with this group of stakeholders, we prioritized the recommendations. So in the end, we had a prioritization of recommendations to collaborate between primary care and HTC.
And so really interesting, like really fascinating that you managed to pull in multiple stakeholders, so both HTCs and primary care and also patients, so users of that service. Did any of the findings that you sort of came across, was there anything surprising in there, or was it all to be expected? Or was there anything there that you thought, oh, we weren't expecting to find this?
So the most important recommendations we found were that there was, first of all, a need for the development of a guideline for physiotherapy in primary care for hemophilia. There was a need for easily accessible information. So for example, contact details of physiotherapists in HTCs. There was a need to improve the reimbursements of physiotherapy in primary care for hemophilia. And there was a need for a two-way and open communication. And the fifth recommendation, we found that there was a need for a decision tool to help determine when contact should be sought between the HCC and the primary care physiotherapist, and when patients should be referred back to the HCC. And that last one is actually something I hadn't thought of myself. It really came up during the discussion with all of the stakeholders. And I really think that it is a promising recommendation, and we're really going to use this in our near future to go on with this work.
So basically the patients with hemophilia were happy to go locally, and the physios were sort of happy to see them, but they just wanted to be able to access support from the HTC is necessary rather than to be overseen by the HTC, or yeah. So they were, both parties were still happy to do it locally, but they needed the safety blanket of the HTC to be available for anything difficult.
Yes, for questions, but also to have a clear guideline of when to contact. Especially the physiotherapist said, I don't really know when I need to contact or when it is safe. So I need more clear guidelines on that.
And that sounds quite easy, but we probably know as specialist physios, even that could be quite difficult, because sometimes even when we see our patients we have a moment sometimes where we're not sure, is it a bleed, is it not, is it something we need to do more with, is it not? So I think highlights that the complexity of the condition, but also the need for being able to live your life as normal as possible in your community, maybe to have less reliance on one center to be the only thing that can offer you some help.
Definitely, and it fits in the new vision of replacing healthcare to local settings and not making patients go to big centers further away.
So it's just localization rather than specialization, I suppose, maybe, which is. Do you think that's been driven perhaps by the changes in hemophilia treatment as well, where the treatments now are so effective against bleeding, and the patients are well most of the time, but perhaps, is musculoskeletal condition the last remnant of the old-fashioned comprehensive care setup, do you think?
Yeah, I definitely think that in analysis we see that this is something which is also going on in other conditions.
And I suppose that's person-centered care. It's very fashionable to say person-centered care, but it's almost localized person-centered care where they accept that they have a rare condition, but they would quite like to be like other people and just go to their local physio or their local primary care physician. Yeah. So I find particularly of interest to me was the part of your paper where you sort of addressed the type of things patients, physios were seeing, and over the average of how many sessions it was to treat a muscle bleed, or to treat after a joint bleed, or to look at sort of rehabilitation for arthropathy. So I know in the UK we're looking at that to try and look at, might be a good baseline to cost up services. So what such services need. But what do you think are the most important take-home messages for other physios across Europe from your paper, but perhaps even bigger than that, sort of services or healthcare maybe from your paper?
So what we found is that most of the stakeholders were very positive about the collaboration between primary care and HTC. So I would definitely recommend, when you think your patient would benefit from frequent physiotherapy, to refer the patient to primary care, and just have a look at the list of recommendations that we developed and see what recommendations fit to your situation and your setting. Because I know that between countries, settings can differ. Even within one country, the setting can differ. So just have a look at the list and see which one fits for your situation and what you can do to achieve a good collaboration in your setting.
Yeah, I think that's key, isn't it? When we talk about collaboration within specialist centers, we often talk about interdisciplinary collaboration and with the patient, but the collaboration with primary care is a newer development, and actually probably requires quite a lot of work upfront on communication, and as you say, being obvious that there is support available, and how you sort of embed that into a service. So what are your next steps then following this publication? Are you planning to create a practice guideline locally? Has that already been done, or is that the next piece of work that needs to be done?
Yeah, we have just started actually with a new project in which we want to develop guidelines for primary care physiotherapy for patients with hemophilia. This will be part of the PhD project of Johan Bloksel. It will be primarily directed at countries with a similar healthcare setting as the Netherlands and with similar roles for physiotherapists as we have in the Netherlands. But maybe in the further future, we can extend this project and make some adjustments or adaptations. So it will be also useful for other countries.
Yeah, I think it's so timely that you're doing this project, and I think countries like the Netherlands, where you have a long history of really good haemophilia care, are probably the countries that are helping to drive forward what the next phase of that care looks like, because your younger patients are, we know from the Olaf's recent publication that essentially boys with haemophilia in the Netherlands are like their counterparts. Their joints are well, their participation levels are good, and actually beginning to see the benefits of prophylaxis. But the outstanding issues with hemophilia and the outstanding issues that people still bleed. And yeah, I think the Netherlands definitely is the forefront of pushing that agenda. And certainly the EAHAD Physio Committee will be pleased that this kind of research is going on, because I'm sure people know that access to physio across Europe for people with haemophilia is a thing that the Physio Committee are really committed to trying to highlight, address, sort of suggest solutions or localized solutions. And I think it's that kind of work that you guys are doing is going to be so important, to create a guideline and then localize the guideline to specific locations.
Yeah, well, thank you so much. I really hope that it will be that applicable. And I do think like physiotherapy is very good, I think, for patients with hemophilia in countries like the Netherlands. But I think also for countries with different healthcare setting, or maybe less access to medication. But we do need to adopt physiotherapy guidelines. So we had to start somewhere. Yeah. But that doesn't mean that I don't think that physiotherapy is very good for patients also in those countries.
Absolutely. I think for lower income countries, or countries that primary or secondary prophylaxis isn't standard, I think often physiotherapy is the most important aspect of care and intervention. And yeah, just acknowledging that there are differences in disease outcomes because of hemophilia, but even we know that there are differences in physio access, and the costs and the access and the reimbursements, as you said, that that needs to be looked at. And it's just I think the future of, if certainly around hemophilic arthropathy, if it's a long-term comorbid condition, physio is quite important, very important. But actually, if it's not reimbursed because it's not an acute problem, well, if there's a reliance on somebody being able to afford to do it, but then also seeing the need for it, I suppose. And so I think the paper like yours and the recent guideline, the recent publication from the Canadian physios, sort of looking at what hemophilia physio can and should be within services, are really, really important to start to build a map of what physiotherapy can be and what it is.
Yeah, and give more evidence that it is important and should be reimbursed.
Yeah, absolutely. So it's so important. Okay. Thank you for your time, Merel. I know this is very short and sweet, but I would highlight to everyone to, if they can, get access to the paper in the Haemophilia Journal, and we'll put the link to the paper alongside this interview. Is it open access, Merel?
Yeah, it is. Yeah.
Yeah. So open access. So there should be no excuses for people not to be able to download it. And if anybody does have any issues, they can contact myself or Merel. We would happily send you a PDF copy if you need anything. So thank you very much, Merel.
Thank you.
Well, hopefully in the next few months, we'll have another interview with another author. And if you've got any feedback on these interviews, or there's anything you would like, any authors you would like us to interview, just drop Angelos at EAHAD email, and we'll see what we can do. Thank you.